What is a special indication valve-in-valve in TAVI?
The special indication for valve-in-valve is basically twofold. One, you can treat a diseased and degenerated percutaneous valve with a valve-in-valve, and you can also treat a diseased and degenerated surgically implanted valve-in-valve. It is actually a very promising step because these patients usually are very sick with an increased risk for surgery, and this is a very, very important step towards a rapid and probably durable solution for a very serious problem.
Okay, your next questions. So, would you tell us about pros and cons of co-valve compared with adult valve in TAVI?
We were talking this morning about pros and cons about those two different types of valves. And quite frankly, it is very difficult to say this is really good and this is really bad about either one valve. I would like to start with what I believe is the common denominator for both, which is even though they are very, very different by design and by delivery, they basically have the same indications, with an exception that core valve can treat at this point larger annulus sizes. But basically we have the same indication, and I believe that the clinical results of both valves, Edwards being out 8-9 years, core valve being out 6-7 years, and I think that's very important to note that as a technology, both valves are successful. Now, obviously, the design and the application and the delivery is entirely different. Whereas Edwards is a balloon expandable valve, which is to say the valve is being delivered and extended by balloon pressure. The core valve is a self-expanding valve with the potential advantage that after deployment there is further expansion of the valve. And if you, for example, have a little bit of aortic insufficiency, you can actually feel comfortable leaving it alone, knowing that in the next 24 or 48 hours, the valve will expand a little further and reduce aortic insufficiency. The downside might be, and is, at least for now, the higher rate for pacemakers, the mechanism of which is not quite clear at this point in time. But so there's a downside and an upside of a self-expanding valve. Having said that, I believe that nitinol as a self-expanding material in body temperature is the material of the future, because all next generation valves will use nitinol as their structure and their frame. I think at this point in time we can say that core valve probably is more able to be applied in larger annulus sizes, and in the foreseeable future Edwards will do the same thing, but that is for now. I also believe that core valve is maybe a little bit more forgiving. In other words, you have the possibility while you deliver this valve to do fine-tuning and correction of the valve with regards to its positioning in the aortic annulus. You know that for Edwards, balloon expansion, it's just one shot. You position it, you control it, and then you blow it up, and that's it. You will not be able to correct it afterwards. Once Edwards is deployed, that's it, and you have to live with it. With core valve, it is a little bit more forgiving in terms of positioning. Also, it's not this one-shot procedure. It's over a couple of minutes that you can deploy the valve with very stable hemodynamics. So basically, if you ask for pros and cons, I don't think there are many pros and cons or advantages and disadvantages. I think important is to know that both valves are functioning very well, and the clinical results are actually quite equal.
Okay, I see. All right, the next questions, actually the last questions. So who will be included as potential candidates of TAVI in the future?
Well, this is a very important question and a very interesting question. At this point in time, I think it is fair to say that TAVI is a fairly new technology. That is to say, that is a young technology compared with aortic valve replacement by surgery. Aortic valve replacement by surgery is at this point the gold standard for dealing with stenosing aortic valve disease. However, now with these promising results, I think that at some point in time in the foreseeable future, we will probably be moving down in terms of risk. Now, the randomized trials in the United States and all the registries in Europe and outside Europe are focusing on the elderly patient with severe comorbidities that are very sick and are either inoperable or considered to be inoperable by surgeons, or have a high risk for surgery because of their comorbidities. So that's the present population that we're dealing with, and that is the focus of the randomized controlled trials partner and CoreValve pivotal trial in the United States. But 2 trials began already, SURTAVI and Partner 2, both of which are addressing the intermediate risk patients, which is a score, an STS score between 3 and 8. So that is the group that is lower in risk for surgery, and we will see what the results are. Now, obviously, these large studies require time, at least 3-4 years, so we will not have anything valid out in the next 5 years. But I think we're moving down, and there's no reason to believe, if we continue with this technology to be successful, the results continue to be good and promising. We don't see any signs of degeneration of these valves, then there's really no reason why the less sicker patients wouldn't profit from a less invasive approach. And I'm sure that nobody likes to cut the chest open if there's a viable alternative to less invasive approaches.
Thank you. Thank you for your time.
Thank you very
Thank
much.
you.